Welcome everyone to our January Board of Health meeting. I'll call the meeting to order and we'll start with a roll call. I can go around the room, that's fine. Councilmember Cathcart.
Present.
And I'm Commissioner Waldriff. Ms. Bagkowski-May.
Present.
Michelle Fossum.
Legal counsel, present.
Maybe you're better at this, Ann. Okay, Ann Pittsnoggle, recording secretary.
Present.
Mr. Charlie Duranoa.
Present.
Commissioner Josh Kearns.
Here.
Board Member Keinholz.
Here.
And Dr. Velasquez.
Present.
And Dr. Thompson.
Present.
Welcome, everyone. Thank you for joining us. Do we have anyone signed up for citizen input? That's the first item on our agenda. And just a couple reminders that Ann gave me here, that the agenda packets are in the binders and we can take those packets home, but please leave the binders and other board manual information here for the next meeting. And we have new technology, so it's very exciting. So hopefully we'll enjoy the new microphones and the new system.
We do not have anybody signed up.
Okay, is there anyone wishing to give any citizen input to the board today? Any input? Anyone wishing to give any public testimony? Okay, well then we will move on to our board reports. For the chair report, I don't really have anything to report since we haven't met since the end of the year, so Happy New Year. I am going to be able to give the committee report though. Commissioner Cooney is not able to be here today, so I can give the report for the Budget and Finance Committee. And we met on January 16th in the afternoon. We reviewed the financial report and the vouchers for November and December. And we discussed a couple items for today's agenda, a couple contracts that you'll see on today's agenda for the Arbinger Institute and Sayre and Fossum, and also the Washington Department of Energy Services. And we moved those forward to the agenda today. And we also discussed the contract with which we're also going to discuss today for our electronic health record system and how we need to potentially move to a different contractor. And so we'll discuss that later today. So had a good meeting. That's all from me. So other committee reports. Mr. Cathcart, did your committee meet this month?
No, there was no meeting of the policy committee.
Any other meetings? We had the executive committee to frame the agenda for today. I think that was it. So, all right, let's get into our agenda for today. Consent agenda, we have the meeting minutes from December 5th, vouchers for November and December 2024, contract with Arbinger Institute, contract with Sayre and Fossum, and a contract with Washington Department of Energy Services. Do I have a motion to approve the consent agenda?
So moved.
Second.
So moved.
Moved and seconded. Thank you. Board Member Keinholz, is there any discussion on the motion? Seeing none, all those in favor of approving the consent agenda, please say aye.
Aye.
Aye. Any opposed? Okay, thank you. Unanimous consent to approve the consent agenda. And we don't have an executive session today, so we can move on to our other action items. So the first item is our 2025 Board of Health meeting schedule. And that is, let's see here, 7A in your packet. And in general, the meetings are the last Thursday, not the 4th, the last Thursday of the month. We skip August, we skip November, and we have an early December, first week of December meeting to avoid the holidays at the end of the year. Any comments or concerns about the proposed calendar for this year? So looking for a motion to adopt our 2025 meeting schedule.
Move to approve.
I second.
All right, we have a motion and a second. Any conversation, discussion? Okay, all those in favor signify by saying aye.
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 Any opposed? So we've unanimously adopted the 2025 meeting schedule. So item 7B is our committee memberships. So if we move to 7B in your packet, we have our three main committees, the Executive Committee, the Policy Education Committee, and the Budget and Finance Committee. And we have 3 members on each of those committees. I just wanted to open it up today. We discussed briefly on the executive team call. If anyone wanted to switch committees, we can do that. If anyone wants to, so just opening that up for board discussion.
Oh, sorry, go ahead, Doc.
Yeah, I would be interested in switching committees just to, not that there's any issue with the current committee, just as an exposure to another board committee. I would be interested. Of course, not to oust anyone from who wants to be on the committee, but just voicing my interest.
And of course, we don't have a limit to the board members as long as it's under a quorum, correct?
Correct. That would mean there are 3 members on each committee.
Oh, okay, okay. So we do need to limit it. I was thinking, yes, you're right. So, okay, thank you, Dr. Blakowski-May.
Chair, if it's
Jornoa?
okay, I request to stay in the Policy and Education Committee. That's okay.
Okay. Board Member Keinholz, do you want to stay on the budget?
I do.
Okay. So I think Commissioner Cuny did want to stay as on the budget committee, and I appreciate her background in auditing and accounting on that committee, so that's always great. I know Kim, she's always got lots of good questions for Kim and good feedback. So I was wanting to stay on that committee too, just to be able to keep on top of the budget for this year as the chair. So maybe we'll just keep the committees, unless, I don't see how we would switch them up at this point, though. If that's okay, Dr. Blakowski-May?
Yeah, absolutely.
Okay, but I appreciate that. I think due to the only having 3 per committee, it kind of makes it challenging. Okay, so we will keep the same committees for this year, but maybe next year we can look at switching those up to give people exposure to other topic areas. If there is no further discussion on that, I look for a motion to adopt the committee memberships for 2025.
Madam Chair, I move to approve the 2025 membership rosters for the Board of Health Budget and Finance Committee, Policy and Education Committee, and Executive Committee to reflect the same memberships as the 2024 rosters.
And I will second it.
Okay, motion and seconded. Any discussion? Okay, all those in favor signify by saying aye.
Aye.
Aye. Any opposed? All right, we've got our committee memberships for the year set up, so thank you. And we're on to item 7C, which is the discussion on that electronic health record system contract. So Dr. Thompson, why don't you give us a little briefing on that?
Sure, and I asked Misty.
Oh, hi, Misty.
She is the Director of Treatment Services, and she will also be with me as we're presenting on the Treatment Services update for this Board of Health meeting. So back on October 31st, the board approved our contracting with Kipu Health, an electronic health record. What happened was that during the contracting process, the negotiation process with Kipu, there were multiple concerns that came up. And we made multiple attempts to work with KIPU to try to resolve those concerns, but every time the resolutions that they proposed continued to leave the Spokane Regional Health District with considerable risk. And it was decided with the entire team that chose KIPU and with the feedback from our legal counsel that we would ask to rescind the approval to go with that EHR, KIPU Health, and to ask to move forward with the runner-up from the process. During the scoring process, these two electronic health records were very close in the scoring, and we asked SAMS, which is the next item on the agenda, to come back, show us a deeper overview of their billing module, and again, everyone from the original RFP process attended that, and it was decided that we would like to move forward with KIPU.
Or move forward with?
SAMS.
Thank
I
you. Okay.
apologize. In the military, I would say, as you were, I meant SAMS. Yes. Any questions?
And we had a detailed discussion about some of the concerns about the contract language in the budget committee meeting and how it wouldn't meet our needs and put the health district at some risk. And it wasn't a shared risk. It was like putting a lot of the risk on the district. And that wasn't something that you were willing, so I understand why. And I really appreciate all the effort to go back and do due diligence on another vendor. So is there any questions for Dr. Thompson about the rescinding this contract offer with KIPU? Councilmember Cathcart.
Yeah, if there are no questions, I would just go ahead and make a motion to approve action item C, providing approval to rescind the contract offer with KIPU.
Thank you.
I'll second the motion.
Okay, we have a motion and second on 7C. Any further discussion or questions? All those in favor signify by saying aye.
Aye.
Aye. Any opposed? Okay, thank you. We've unanimously approved rescinding that contract offer, so that moves us to 7D.
Thank you. And in your packet, you do have what we call an SBAR, a situation, background, recommendation, and cost document on the SAMS EHR. And as I've already mentioned, we went through a very diligent process to ensure that the entire committee that had originally scored was on a part of saying yes to this this electronic health record. And the kind of the wonderful thing about this is that it actually has some functionality that we're extremely excited about. And it comes in at a much lower cost than what KIPO was coming in at. So, did you want to say anything else, Misty, about going to SAMS?
No, just that the decision to make these changes and reevaluate with SAMS and having the follow-up meeting and evaluating the billing component was a unanimous decision across the board with all members of the team that were involved in the process.
Any questions for Misty or Dr. Thompson on this one? Okay, looking for a motion. Dr. May.
Move to approve.
I'll second.
Okay, we have a motion and second to approve item 7D. Any discussion on the motion? Seeing none, all in favor, please signify by saying aye.
Aye.
Any opposed? Thank you. We've unanimously approved the contract with SAMS. So looking forward to having that system.
Yes.
That'll be great. Thank you very much. Okay, then actually we can move right into your report, Dr. Thompson.
Yes, thank you. So we're going to go over the treatment services update first, and Misty is here to help me to answer any questions that you might have. And then we'll talk about the strategic plan, and lastly, some important legislative dates that we wanted to make sure you were aware of. So what we're showing you today is 2024 statistics and what did treatment services do in 2024. And this is a chart that you've seen before, and it shows you our expenses and our funding. The funding is the orange line, the expenses is the blue line, and you can see just by looking at the chart that we have once again ended 2024 with excess revenue. The preliminary results indicate that treatment services will have a $950,000 surplus when everything closes for 2024. This slide, I'm not going to read each line, but I'm going to give you a few minutes to absorb it. These are the numbers, the actual numbers of what the staff at treatment services accomplished in 2024. This does not include our mental health program, because that program is down to just one person. And so I wanted to make sure this is just opioid treatment program by itself.
I have a question about that.
Absolutely.
The individual counseling sessions, can those
Dr. Keinholz, do you have your microphone on?
Sorry. The individual counseling sessions, are those sometimes repeat people? Maybe they came into the program and then fell off, or what is the attendance? Like, who are the people that are attending those
That's a
sessions?
required component of opioid treatment programming, that they have to have the counseling sessions as part of their recovery. And it's with substance use disordered professionals who are certified to provide that support.
How often are the sessions? That's what I'm trying to
I
get
will
at.
now turn it over to Misty, because I believe they're required to have at least one per month. But Misty's the expert.
So as far as the individual counseling services, the federal requirements have actually changed recently, and they are no longer a requirement, but they are highly recommended. So internally, what our requirement is that the individual seeks engagement with their provider or their counselor on a minimum, at least on a monthly basis, whether it's counseling or individual counseling or group therapy services. In the event that an individual is unable to attend those, it's part of the process is that the counselor then follows up by phone calls, case management, meeting with them in the dispensary. But generally speaking, it's at least on a minimum basis of once per month.
Thank you.
Yes.
Yes, Commissioner Kearns?
Could I just add, to kind of help give a little bit of context on each of the numbers, what's the total population again, or census number for folks that are in the treatment services program again?
Yeah, in 2024, we served 1,602
Okay.
unique clients.
Thank you.
Yes, Councilmember.
So I guess, is that averaging then about 4 to 5 individual sessions a year then for each of those?
For each individual patient?
Yeah, I mean, 7,800 divided by 1,600, I'm guessing.
Well, and that's not necessarily accurate, because with those 1,602 individuals, that also includes all of our individuals that, what we call courtesy dose. So a courtesy dosing individual is someone who is coming to our program to receive medication that may be coming from what we refer to as their home clinic. So if they're coming from across the state or another state, and they're receiving services from us on a temporary basis, or they're even receiving medication at the jail. That would be a unique individual, so they wouldn't necessarily receive counseling services, but we would still be providing services and receiving payment. So the counseling is part of that, but so is the group therapy as well.
So in terms of the numbers, would it be possible to get a breakdown of, how many are sort of in that category versus the ongoing, folks that are participating in an ongoing way?
The courtesy versus ongoing and regularly engaged.
Yeah.
Yeah.
And Jim, I think that's a good idea.
Yes, Commissioner.
Can you clarify, so transfers/discharges, I assume transfers mean that individual went to another location, or maybe they have ceased receiving services with SRHD and has gone to another clinic. Discharges, can you tell what that is?
Yes, so transfers and discharges. So, for example, if Fred Flintstone was enrolled in services and just began not coming in consistently and then essentially walked away, and we just stopped hearing from him despite efforts made to reach out to him by way of phone call, and reaching out to him in any way that we had authorization for communication. And essentially, we just stopped hearing from Fred, and he just discontinued services with us. That would be considered a discharge.
Okay, so not a situation, where they would communicate, I will no longer be coming here, that doesn't qualify as a discharge? then?
Yes, it would.
Oh,
If
it
they
would.
decided
Oh.
that they were no longer going to be receiving services, but if they were
Okay.
transitioning to another program, that would be a transfer where
Got
we
it.
would collaborate with that partner.
Okay.
And make sure that they had a seamless transition to that other program, whether it's another opioid treatment program, an OBOT, or if they were, an OBOT is an office-based opioid treatment.
Okay, thank you.
And it is important to recognize that the numbers for an opioid treatment program are fairly complicated and convoluted, because we are talking about individuals who are struggling with and battling an addiction. And so we constantly have people coming onto the program and leaving the program, coming back to the program and leaving program, and coming back to the program, and we just keep working with them because we are a harm reduction based facility where we are wanting them to, we don't ever shame any of our clients for leaving the program. We always welcome them back. And I think Charlie has a
Oh,
question.
go ahead, Charlie.
Missy, you said that it's been required before, but now it's changed to optional or highly recommended. Was that a decision that was brought down federal, state? Was it our decision? And would that probably reflect the 7881 probably is going to go down next year? Or in that history, what do you think?
So that's a great question. And that was actually done at the federal level through SAMHSA, and that has taken a very long period of time. And that started essentially with the changes in the take-home medications with COVID. Those regulations actually were just released back in December. And so all of the OTPs, opioid treatment programs across the country, are still working through all those regulations to see what all that means and the changes that that's going to require. As far as the individual counseling sessions, it's possible. Nationwide, it's not recommended. It's actually highly recommended to actually increase those numbers, to increase engagement, and to see further success with assisting individuals with the foundation for their recovery efforts.
Thank you.
Yes.
So on that then, are we prohibited from making it a requirement as a part of this program?
No, we're not prohibited. It would not be considered best practice if we make it a mandate and a requirement. We would be encouraged to do the same as the federal level and the state level to make it highly recommended, however, not discharge individuals or have punitive outcomes if they do not engage. So those are things that we're working on internally to look at what the federal and state guidelines recommendations are.
Okay, and then on the discharges, I guess my only question would be, what sort of, or have we done any sort of follow-up evaluations, trying to understand exactly why individuals left and whether or not it was really just their own something that we had no control over, or if it was something about the program that could be improved upon? Just curious.
Unfortunately, due to the nature of the work that we do, we're not able to do a whole lot in the way of follow-up once they leave our services. However, when they do come back, as Alicia alluded, or Dr. Thompson alluded to, we are able to ask those questions when they return to us. And oftentimes they do return. And so we do find those questions out. And more often than not, what we find is that it's environmental, it's family related, it's financial, it's all these other external factors that play a part in that.
Gotcha.
And more often than not, they prefer to come back and receive services because we continue to try and meet them where they're at.
Thank you.
What would you say are the top 3 reasons why people miss their counseling sessions? Is it transportation or?
I would say the top 2 would be transportation and childcare.
Mm-hmm. Thanks.
Absolutely, transportation and childcare.
Did you have another slide that you
Yeah.
were, okay,
Yes,
I
we
think
do.
we were
Yes,
anticipating
we-
the next
we
slide
were
with some of the
waiting
questions.
until all the questions about this slide happened.
But this is really interesting. Thank you for providing this. I don't think we've seen this data before.
And then this slide, we're anticipating a lot of questions as well. Because what this slide really digs into is what is the magnitude of the medication-assisted treatment that we're providing to our clients. And one of the things that we're immediately anticipating is that there's 2 methadones there. What's going on with that? And there's 2 different types of methadone that we dispense. And so I'm going to step aside and let Misty step up.
So on that first one, you'll notice that there's 373,582 milligrams or doses. And what that is it's our cherry methadone. That is the typical liquid methadone. However, there are some individuals that have an adverse reaction to the cherry and the methadone and that cherry typical one. So we have clear, which is that second line item. And that clear is not something that is a primary option for a lot of individuals, but for those that do have an adverse reaction to the cherry flavoring, we have that available as an option so that we can make sure to still continue to meet their needs. We do have, I believe it's Crystal Light that we add to it because it is a very undesirable taste, we've been told. I believe the reference that was made was gasoline is what it is similar to. And so we try to ensure that we have options such as Crystal Light available to help with that so that they're still able to receive their medications and continue to move forward in their recovery. And then, of course, our final one there is the buprenorphine naloxone film strips.
Any questions on this slide?
Do you anticipate changes to the distribution of the use of these medications? Buprenorphine is obviously pretty popular and a safe MAT. So just wondering if there's a trend toward different medications in the program.
So just so I understand, and I'm clarifying here, so are you asking, do we anticipate seeing an increase more towards the buprenorphine naloxone? Potentially, I mean, it's an option. However, with the increase in the fentanyl crisis in our community and nationwide, Oftentimes, the buprenorphine does not meet the needs and it doesn't hold the patients, and the majority of them have oftentimes found that they've tried it already and it has not held them in their withdrawals and their cravings and the issues that they're experiencing when they come to us. So more often than not always, by no means is it always, but more often than not, they do find that the methadone tends to hold their withdrawal symptoms at bay much more effectively than the buprenorphine naloxone.
And Misty, can you talk about how we make sure that it's their choice on which medication?
Absolutely. So our medical providers actually at intake meet with every individual and explain their options to them and let them know that they do have that choice of the methadone or the buprenorphine naloxone, otherwise more commonly known as Suboxone. And they are informed of that. They know that those choices are theirs, and they are involved in that shared decision-making process. And with that, when the individual communicates with a provider that they want to receive services and they want to receive a certain medication because they've had an experience with this one or that one, that's a shared decision-making process with their medical provider that we have on staff.
Do we have a sense, I guess, of how this sort of breaks down with regards to other providers? Is it very similar, do you think, in terms of what they use on their patients, or is there maybe a different mix, different
Within
breakdown?
opioid treatment programs?
Yeah.
Yes, it's very consistent.
Okay.
I was just, do you have an idea as to why so many folks would choose the methadone over the naloxone? I mean, people are more based on this chart, people are more likely to have an allergy to the cherry flavoring than they are to choose the naloxone over methadone. It's just that's such a great
Yes.
difference between those two. Do you know why that is?
Yes, because the buprenorphine naloxone is a partial agonist, and whereas methadone is a full agonist. And where methadone will fully block the withdrawal symptoms and the cravings, the Suboxone will do that, but it has a ceiling, it has a cap. So essentially, if an individual has a tolerance that goes beyond that cap, the buprenorphine naloxone will only go to a certain point, whereas the methadone can go much higher than that. And I see Dr. Velasquez over here nodding his head, and he might be able to explain it in a more understandable method than.
So the 14 individuals that are on the naloxone, would some of those people then be in a situation where maybe they started on methadone, they've brought down their level
Absolutely.
of withdrawals, and then they
100%.
shift over to
100%.
to Suboxone? Okay.
Absolutely.
Okay.
And we do encourage that for those individuals who are seeking to taper their dose down and don't want to end up just immediately ceasing their medication at, going to zero. We do help encourage them, and our medical providers are wonderful at working with the individuals.
Do we ever utilize, and again, their choice, but do we ever utilize sort of out-of-the-box types of treatments, ketamine, things like that might have an impact, psilocybin, different
No,
things like that?
we are not licensed, as an OTP, we are not licensed or authorized to utilize those types of medications. Those require separate licensures and education requirements, storage requirements with the DEA, and as an OTP, we do not have those license or authorizations at this point.
Could I follow up on the new rules that you mentioned around the counseling and maybe not making that mandatory? What are some of the other changes that came down in December that could be, do you think, beneficial for OTP programs?
So I don't want to speak out of turn because there are a large number. The entire federal regulations, they had not been revised since, I believe, 2015, and they finally came out with the new regs in December of 2024. So just as an example, the take-home medications was a significant change. There were a lot more requirements in order for individuals to receive medications. They had the requirement that an individual must be engaged in services and approximately a list of 8 check boxes before they could even receive a weekend to take home. And then they had to maintain that for 60 days and then continue to maintain this checklist for another 90 days before they could get what we refer to as Monday, Wednesday, Friday. And then they had to go another 90 days for the twice a week, and so on and so forth. However, the new regulations leave it at provider discretion with clinical appropriateness. And with that, it leaves it much more patient-centered and really looks at the benefit to the patient and increasing the success of their recovery and ensuring that coming to the program is therapeutic, beneficial, and is not a hindrance to their life. So that's just one
Yeah,
component.
I was just really glad to hear that, because I don't know if it's when I did my tour, when you guys opened the new building, but I was hearing about that those rules hadn't been updated in so long, and the pandemic forced different strategies
Absolutely.
and allowed for more flexibility, and it turned out that people were, certain people were able to handle the take-home, and it was successful. So I think it'll be interesting to start implementing that, but here in our program. But I just think that's really important, that if someone can handle the take-home, we shouldn't make them wait 9 months.
Absolutely.
To be able to do that, because of the barriers that you're just talking about, Patricia, like childcare and transportation and all of those things. Those exist always. So if there are folks that can show that they can responsibly have those doses at home, maybe we can get to better outcomes. So anyway.
Absolutely, and I think that's the ultimate goal, and that's what the individuals that worked within SAMHSA were really aiming for.
Councilmember.
Yeah, I guess with that, if we're gonna, at least with some folks, expedite the take-home and then not mandate counseling, how do we truly know that there is really big improvements that are being made?
So, and that's multifaceted. And that's going to be a component that the counselors that are assigned and the providers that are assigned to that individual will have to ensure that there's clear communication between the provider, the counselor, and the patient, and really working with them to make sure that there's not one clear point that's being reviewed. It's their urinalysis, it's their environment. Are they engaging in their community? How's their recovery doing? Are they communicating? Are they re-engaging with family? There's a multitude of different capacities that is going to be taken into consideration. And so while it may not be a hard and fast requirement, it is still, again, highly recommended, and it's something we will still be emphatic about encouraging and ensuring that our staff are reaching out and making that contact.
You have some more slides for us?
Oh, yeah.
Oh, boy.
Yeah.
Okay.
Okay, that's what I was getting ready to ask. Are you ready for the next slide? Okay. So this just covers the percentage of appointments that have been checked in and the percentage of no-shows. And again, this does not mean dosing, because people walk into the clinic for dosing and they don't have appointments. They, like we have a specific hour set aside for those who have jobs and are working. That's the first hour of our clinic. We want to make sure that all of the patients that we have and serve who are working can get dosed before they have to get to their job. And this is primarily about the counseling sessions, the group sessions, the annual wellness assessment. I don't believe that's what we call it.
Annual health history.
The annual health history, and appointments like that. So. And this is just the slide that covers the number of individuals who were turned away from service from July 1st through December 31st in 2024. And so if you recall, that has been a topic of how can we do a better job of making sure that every single person who walks in our doors can be assessed and enrolled into our program if they are appropriate for our program. And so this is what it looked like for the second half of 2024. And we did not start tracking this until right before July 1st. So, do you have anything you want to say in addition, Misty?
Can I ask what is not appropriate for our services? Those
Oh,
four
sure.
individuals?
So someone that's addicted to methamphetamine, they would not be appropriate for our services.
Additionally, not only that, but someone who's seeking services for pain management. Because while we are an opioid treatment program, we cannot treat pain. We can only treat the addiction component.
So I'm really trying to get at the numbers of the no available spot versus how many people are actually being served. And so I want to know specifically, why is there no available spot available? In contrast to the numbers of people that we served before we went into the new building.
So with that, on any given day, we have a specific number of staff. And in order so if I were an individual seeking services, I have to meet with the front desk, I have to meet with a clinical assistant, I have to meet with a counselor, a medical assistant, and a provider. And that is an overwhelming amount of people to meet with. Now, a lot of that can be worked around. However, the counselor and the provider are key components to that. All the other pieces are key as well. However, the counselor and the provider are the two that we really have to make sure we block out an adequate amount of time in their schedules in order to get the intake and the assessments done. These intakes and assessments for new incoming individuals, altogether, it takes upwards of 3 to 4 hours. And unfortunately, that is just the reality. And it's not just us, it's all OTPs. And it's just the reality of the work that we do. And so when we bring in new individuals, we have to really ensure that we're taking the time, one, to be thorough. We're doing what we can to make sure that they're involved in their choices and what care they're receiving. And so really making sure that the schedule encompasses that. So if we've got, we'll say, just a number, 10 people that come in, the reality is that we're not going to have 10 people that have time to get 10 assessments, because that's 40 hours. I mean, just right off the bat, that's going to be a 40 hours worth of work in one day. When we have a limited number of staff, whether it's counselors, providers, or other positions, we've got an incredible amount, an incredible staff of counselors and medical and AAs and support staff across the board. But the reality is it takes a lot of work, and it takes every member of that team to get it done. And the data that has to be entered into a number of different systems, it takes a lot of work. And they are really good about working their schedules around, trying their best to get as many people in as possible. And they're actually, lately, they've been really gracious and really squeezing their schedules as much as they can and really cutting in on their time for documentation. They're still getting their documentation done, but they're really making sure that they can do what they can. So to answer your question succinctly, it's really about schedules and the sheer volume of time it takes to get one intake done.
Are you seeing in some of the other places where you go to these conferences and things like that, are you seeing ways that could be implemented to expedite some of these processes outside of additional FTEs?
In some aspects, yes. We're trying to look internally how we can be creative and working within our current staffing and having our staff work at the top of their positions to ensure that everyone that's there is able to do their job and they're doing it well. And they are. And one of the things, just as an example, is we've got our providers starting next week. They've made adjustments to where they're going to be making a shift and how they do their intakes so that they can, and that's just in our medical providers, our ARMPs, where they will all be doing intakes, but one will be designated for each day. So not only will they all have their intakes for the day, that one provider will then continue to do intakes throughout the day.
So it sounds like you're doing some creative look at the schedules and how you can maximize the people you do have
Correct.
before you're looking to add more staff. How do you maximize? So are you going to be able to track over the next month or two to see, do those changes result in, less people who have to wait, maybe a week to get an appointment? Or I'm not sure how long it would take to make an appointment.
Well, and we try to make appointments. Unfortunately, appointments generally don't work real well when individuals are coming in. But yes, we will be able to track.
Commissioner?
Just trying to kind of wrap my head around some of these numbers. So, for example, the no identification, those 11 individuals, had they had identification, do you think they would have been enrolled in the program, or would that have just added 11 more to the no available spots?
With sheer speculation, I would say, yes, they potentially could have been enrolled.
Okay.
But I'm going to go back to Commissioner Waldrop's question earlier about the changes in the regulations.
Okay.
That's one of the changes.
Okay. And just for comparison, so in this 6-month time frame, there are 193 people, for one reason or another, that were not enrolled. How many people were enrolled in that same 6 month? I assume that's the next slide, but, oh, no?
This doesn't have
Nope.
the number enrolled. Sorry, we will make sure
Well, it's all
that the
good.
next time we present, we will have that data.
Okay.
Yeah.
And I have a question also. Seeing that we're going to be talking about the new EMR, and you said that it takes a lot of time to enter that data, with the new EMR, is it going to reduce significantly so we can
Yes.
actually add more people?
Absolutely.
Okay.
That was one of the beautiful benefits.
Yes. Yeah, right now, what happens is we have a staff person on staff who does a wonderful job using Power BI to import all of the raw data and and gets all of the information that you just saw, but it is a time-consuming process. And so he does a great job, but our EHR will be able to have a real dashboard for us.
Yeah, just a question. Do you have a rolling wait list for, so some of those 177 that were not able to get care or get enrolled? Is there some mechanism by which they come back on a subsequent month, or is there a cancellation list or some other mechanism by which there's another opportunity to get engaged in care?
No, we don't necessarily have a wait list. It's always, I don't want to say always, I spoke out of turn there. It's typically a first come, first serve. However, out of that number, it's a little misleading, because out of that 177, say I come in today and I'm unable to receive services, I can come back tomorrow, and if I still can't get in, that's twice. So maybe I come in 5 days in a row and I can't get in, but I come in on the next day and I'm able to get in. So I could, because I wasn't able to get in that day. And if it wasn't because of an ID issue, it was because there wasn't a spot.
So I would love to get maybe a broader sense of the data then at our next meeting to really break down unique versus repeat. I think that's a big necessity to really understand these numbers. And then to the point about scheduling or wait lists, I just wonder if in fact it could be that they would get in the next day. Why couldn't we just schedule them the next day when they come in the day that they can't get in?
And we have done that with those that are willing and able to do so.
Okay.
And oftentimes when they do schedule, and that was what I was trying to state earlier, is that oftentimes when they schedule, they don't show.
Gotcha.
For one reason or another, whether transportation, childcare, or their addiction issues.
Sure.
But we do make those efforts.
I'm thinking of sort of other instances, where there's long waits and long lines. Sometimes they say, those entities will tell you, like Wednesday afternoons tend to be better than, say, a Monday morning or something like. I mean, are there times that are better than others that you maybe tell these folks, like, hey, yeah, you're coming in, this is our busiest time of the week, Monday at 10 maybe is always jam-packed. Do you try to tell them, like, you'll have better luck if you come Thursday at 3?
Honestly-
are there trends in sort of the workload, I guess, that can help give folks a better idea?
Yeah, honestly, the trends tend to go with the seasons.
Oh, okay.
And this time of year, the trends tend to go that the numbers decrease
Okay.
with the colder weather. And that's, it honestly just kind of flows with the season.
Well, this has been fascinating. Thank you. Thank you for the data, and we want even more data, so that's great.
Well,
And
I'll work with Adam on that and make sure to get you guys more for next month.
thank you for being here, Misty. I appreciate it, and we'll look forward to more info next month, and good luck with the new provider schedule. I hope that helps get people in more quickly. Okay.
Okay, are we ready to move on to the next AO? Okay, so this is the strategic plan, and what the next few slides are the same presentation that was sent out with a couple of edits that you had the opportunity to see at the special staff forum, and that did get sent out along with the recording of it. So I'm not planning on going through this slowly. This is more of a refresher and a reminder. And so this is our draft strategic plan. It's basically your first touch at it. And then next month we will be bringing it to you for approval. So what is the rationale behind doing a strategic plan? We listed it out. We've been operating without a strategic plan since 2021. We made sure to include our employees extensively in this process. And later I'm going to show you the preliminary results of the survey from staff on the strategic plan. And once this plan is approved, it will help all of us to have kind of a North Star that we are all heading towards and working towards in the agency. There were some minor tweaks to our vision, our mission, and our values, and the survey did give feedback on how well employees thought the vision, mission, and values, the changes, if they like them or not. Again, I'll be showing that data in just a minute. The executive leadership team will be digging in to the responses because they were able to give us qualitative responses. So we will be digging into those qualitative responses and just tweaking and tightening up some of what you're seeing. Okay, so the strategic goals, goal number 1, be visible and trusted in the community. And these objectives are some of what's going to be tightened up, okay? Goal number 2, be a model for evidence-based decision-making. Again, these objectives have already been a little bit tweaked since the presentation for the all staff. Goal number 3, a workplace where everyone is valued. And goal number 4, streamline internal processes to improve transparency, efficiency, and consistency. And I want to note that each of these goals has 2 executive leadership team members assigned to be the leads for each goal. And as we move forward, after the strategic plan has been finalized and adopted by the Board of Health, we will be going deeper and assigning leadership leads to each of the objectives. And in this manner, we anticipate that this will not be a strategic plan that's just put on a shelf, that we have people who are accountable for making things happen in our organization. And we're pretty excited about that. Okay, so the next steps, at the time of the staff forum, we let people know that we were sending out a survey. We did assign the leads, and we will have it ready for you by next Board of Health meeting on February 27th. So this is what I'm excited about, the feedback that we've gotten from staff. And it went out to all individuals with an SRHD.org email. So I have no idea who the 77 people are that responded. It could have been some of you. We don't know. But this are the results of our goal number 1. And just over 70% said very important, and just under 21% said it was important. And that's a pretty solid buy-in for that goal. Similarly, goal 2 had right at 59% who said it was very important, and just under 35% who said it was important. Goal number 3, we had just over 76% of our staff say that this goal number 3 is very important, and just under 20% who said it was important. And so that was good news. And then for goal number 4, we had right under 62% say it was very important, and right at 27% who said it was important. Before I go to the next slide, do you have any questions about the feedback? Yes, sir.
Just curious, so were there a number of additional goals that failed to get support and that's why they're not included, or did we only test these 4?
I'm looking at board members to help me to respond to that question, because it was a really dynamic process.
I mean, we started with a lot of goals at the workshops, and then we had to whittle them down, and there was a lot of, even the wording, and I think there were 2 goals. I mean, this is just my memory. There was one around budget transparency, and then there was one about efficiency, and we kind of merged them into this goal, for instance. So that's kind of one of the things that sticks in my mind. But Patricia, you were in a lot of those meetings as well.
Yeah, I don't think we eliminated really anything. We just combined things that seemed like they were duplicative or.
Just one other comment. In some ways, transparency, which I think is probably the most important thing that any governmental agency needs to focus on. But in some ways, it's contradictory to efficiency, and it can also kind of derail some things or make things take a little bit more time. And so just thinking about, what does each word actually mean in terms of what we're thinking about here.
Yeah, we'll take that back. So then we asked about the vision, and on a scale of 1 to 10, it has a rating of 8.4, which I feel is great. That's a pretty significant support for the vision staying the same. And then our mission statement, a little lower at 8.2. People, our mission statement is rather long, and so the majority of feedback is, could we get it to a place where we could actually remember it and just quote it?
On the back of a napkin, right? That you
Yeah.
remember what it is.
Yeah. And again, all of the qualitative feedback that we gathered in this survey, we will be reviewing it We will be incorporating the feedback that we can, and we'll also be having a greater understanding of where we can't incorporate it, where can we help our employees to understand why we can't incorporate it. Okay? And then the overall rating for the entire strategic plan is 7.7. And so, okay. And I don't know if you noticed, but like there are 0 not at all satisfied on any of these. So,
Well, I noticed that. there were some not satisfied on the previous ones.
oh, 1, yeah, I see that.
But I was curious if you got feedback from the people as to why they weren't satisfied or,
Yeah.
yeah, okay.
Well, yeah, I put in qualitative response options for every single one of these. So we will have a greater understanding. And the survey is still open, but I had to close it last night in order to get the presentation ready for today. And so it's still open, so any staff who are listening, please, if you haven't responded, please continue to respond, because ELT and our Erin from, sorry, name just flew out of my head. What's that? Village Reach, thank you, Dr. Velazquez. She will be helping us to incorporate what we can. So, any questions about that?
I just really appreciate the survey tool. I think that was really a cool way to show the data from the survey.
Mm-hmm, thank you.
And I'm excited that there seems to be definitely positive support for many of the goals and what the committee has been working on. And
Yeah.
I remember back to the first meeting that we had, and there was a lot, and we were a bit overwhelmed. Missy's nodding over there, because it's so hard to distill all the work of the health district into, specific goals and objectives. And so, but it's important work because you can't do it all that was my one question. What is the time frame for this strategic plan? And I missed that. What's the estimated kind of shelf life?
So it's 5 years.
Okay.
It's 2025 through 2030. Yeah, and so we have 5 years to be working on these goals.
Okay.
To accomplish them.
Tricia?
I'm curious about how you feel about it, just because it is so central to your job and how you run everything here. And so I'm wondering how you're feeling about things.
I'm so excited, Patricia. I am so excited about this strategic plan. I think it really gives our agency some really good direction in how we can improve everything from our and of course, everybody probably guessed, but Dr. Velazquez and, is it not you, Kelly? I think it is you two, that are the executive leadership leads on goal number 1 about our external partnerships and collaborations and being known in the community. And so I'm absolutely excited to see how we're going to change over the next 5 years. Yeah. Any other questions?
So are there any, oh, yes, Doctor.
Yeah, I just had a question about social media as a tactic for the visibility, transparency, the communication, some of those things that are very prominent in the strategic plan, appropriately so, but it's kind of silent on social media, and just wondered about that, if that had been discussed, because that is kind of a sign of the times, whether you like it or not, that there is a lot of activity on social media. So just wondering what the thoughts were on that.
Absolutely. When this is finalized, we will definitely be doing a lot of dispersing the information throughout our community so that they are aware of what's happening. I mean, some of the things like goal number 3, where every employee is valued, we want anybody that's looking for a job and is appropriate for a position at SRHD to hear that we really care about our employees. We really support our employees in the work they do. And 5 years from now, I anticipate that we will become an employer that people are really hoping to come and work for.
So is there any board member that needs more information or wants to review more of the strategic plan before our board meeting next month, or feels like you need a little bit more? Just if there's anyone that does need more information or wants to review, I know you sent out links, so can you still use those links to
Absolutely.
see
Yes.
the draft plan? And how long is the survey open again?
We will probably, let's see, today is Monday's February 3rd. We will probably leave it open until about February 3rd, 4th, 7th.
Okay,
February
another
7th.
week or less.
Yeah,
Okay.
and then we will be getting with Village Reach to incorporate any additional feedback from the survey. Yeah.
Great.
And then as soon as that draft, the full draft report is complete, we will be getting it out to the board for review. And then, of course, we are hoping that will be before our committee meetings. And then we'll discuss it in committee meeting.
Okay. So don't be shy if you
Exactly.
reach out to you if
Yes,
there's questions,
please.
needing more information,
Absolutely.
and you'll get us a kind of final, I don't want to
Yes.
say final, but a finalized draft
Yes.
before the meeting so we can review that
Yes.
ahead of our February meeting.
Correct.
Okay.
Correct.
Sounds great. Well, I've been very impressed by the consulting team. They're I don't know how they do it with like all of us on Zoom giving our feedback and breaking out and then nitpicking over words, and they are masterful meeting to meeting, trying to keep the momentum going and trying
yes.
to keep the tasks accomplished. So I've been impressed with that organization, and I'm looking forward to see how they incorporate all the final comments.
Yes. Yes. Thank
Final
you.
challenge.
Thank you.
Okay. Thank you.
And my last item is just you have a handout in your book that just provides you with some important legislative dates. And so just wanted to make sure each of you were aware of these dates. And I believe that Lola is now forwarding the Wasalfo overview of what's coming up in the meetings. So the legislative hearings and stuff. So, okay, if there are no other questions, we will move on to the
think
health
it's-
officer's report.
Do you want to do health officer first or financial? We have finance listed first, but
Okay,
they can-
sorry, I apologize.
Kim's ready to go. Okay. Okay. All right, Kim, on our financial update, and then we'll move to Dr. Velasquez.
Thank you. Good afternoon. So as I mentioned, no slides. Your financial report is in the packet, and we're looking at the November 2024 report. We are still working very, very quickly to close out 2024, so hopefully I can bring a December report, maybe by February, but certainly by March. It takes about 30 days following a month-end close to get those invoices from our vendors and contractors, so we're still processing. But for November, where we're at would be a 92% of the calendar year, and so we're under budget in both expenses and revenues. Our expenses are coming in at 84.9%. So we're under budget there. But this is a pretty routine month, so not missing any kind of expenses at this point. On the revenue side, we are at 87.6%, which is a little bit less than the 92% for the year. Some items to note is at the very first top line, the federal indirect grants and state grants. Although we have some billings showing up in November, we still anticipate additional billings. That's always happening a month prior, or excuse me, a month following. So we have some more revenue that will come in there. Our foundational public health services, about halfway down, we have received 113.8% of what we anticipated. There was an increase to the FPHS funding. Mid-year, we had a couple additional projects that were allowable. So that came in higher year to date. And then Spokane County's contribution, we've received all 4 quarters from the county. So thank you, commissioners, for that. I mentioned last month also our interest in other earnings is coming in higher. So the next line, we're at 191,000 above budget for based on the interest rates and the investment pool earnings there. So overall, we're closing out November just under 1.5 million surplus to our reserves. And I am anticipating this to be very similar for December through December 2024. We do have treatment services, as Alicia and Misty mentioned, they're running a surplus. We're estimating between 950,000. We also have a few projects that we're going to be using local dollars that didn't materialize, that were no longer necessary. So that's a savings back to reserve. So I am expecting a surplus for 2024. But right now, as of November, our unassigned reserves is 26%. Our goal is 20% of our budget. And then our overall total reserves is at 19,153,000. Any questions from anyone?
Thank you, Kim. Any questions for Kim?
Thank you.
That's looking good. Thank you. Dr. Velazquez, our health officer report.
Good afternoon, everyone. I've been speaking all day, so my voice is kind of going. I've had, I think, 5 presentations this week, so it's been kind of interesting. So 2 things. I want to acknowledge that we have some nursing students from one of our academic partners, WSU. Say hello. And I made sure they're all going to stay in Spokane after they finish. They told me they were, so I'm assuming you are, because we do need a lot of nurses. At one point, we had a gap of about 400 in the region. I think we're doing a little bit better, but we still need a little bit more, because I think the retirements alone in the next 3 years are massive. So right before I came here, I was doing a panel, an opioid panel at Eastern Washington, with Sheriff Knowles and Sarah Spear and a couple of other people. And I don't have an update today on the fentanyl roundtable. I'll have one next week, but we have some challenges in front of us, and we have some opportunities that we have to tackle. And one of the things that I was looking at is somebody mentioned social media, some of the social media impact on this particular issue, particularly on youth and young adults and children. And if you're ever interested, I have a whole repertoire of the emojis that are used for communication that signify specific transactions, which is a little bit scary to me, actually, because I didn't know that the universal symbol for drugs, illicit drugs, is a maple leaf. Do you anybody know that? Yeah, so if you, no, it has nothing to do with Canada or maple syrup, but so anyway, I got that from my friends on the DEA. And the other thing I have is this collection of so vaping, which is a significant concern, particularly the newer liquid packages that look like Fruit Loops and all these wonderful things that kids consume, some of which can be injected with fentanyl. So anyway, I'm going to transition to Board of Health report, but just for you to know that we are tracking all of that. And actually, our social media and digital media, Maddie Person was with me there to documents because already going up on social media, because we do try to share as much as we can. So today I have a number of updates. I'm not going to be very long because I want to make sure you have plenty of time for Jassy over there. But this opioid thing was still in my head as I'm driving here. So I wanted to share that with you. And hopefully I know how to use the new system. I do. A few updates on some things that are happening, just to give you some perspective, things that we have discussed before, but there have been some either trends or changes that are important for you to know. Starting with communicable disease, which we try to talk about. We don't talk about all the communicable diseases that we track, but just the ones that are either we're tracking nationally for significant concern or we're tracking locally because we have a local concern. But we could talk about a lot more than that. So pertussis, not going away, not going to go away anytime soon. By now, we have in the state of Washington about 2,040 confirmed cases, which is a significant number. If you look at the same time previous year, it was 87. So the difference between 87 to 1,040, I didn't do the math, but it's a lot, whatever that number is. And we continue to see a lot in Spokane County. I think we have a little bit of, you see a little bit of a tapering off here at the end of 2024. But just to give you some perspective, the age groups that are have been impacted are pretty typical, with one interesting difference. I'm going to show you that in a second. That's part of the demographic that has the highest impact, if we're going to talk about that. But just to give you an idea that this is encompassing all generations. We actually have everything from infants to later youth and seniors. And actually going to the overdoses, we've had overdoses increase in people age 50 and over, and several in the 70 to 79 and the 80 years of age. So it's kind of, it has nothing to do with pertussis. It's still, these numbers are still floating in my head. Apologies for that. But we can see just by looking at the numbers, we continue to see an area in Spokane is an area of high density. I do have to say, there was at least one school closure that the school decided to close because about 50%, they had a 50% absentee rate, which we shared with you. And we do know that when school started, we started to see a significant level of transmission in there. But our partners in K through 12 are doing a great job of mitigating risk. Now, Spokane continues to be number 2. It's good not to be number 1, but actually, we are number 1. No, we're not number 1. We're number 2. I would prefer that we're number, 79 or whatever it may be. But based on population, is a significant number, doing a little bit better than Clark County. I think the key here is continue to encourage providers to confirm by testing, not just clinical symptomatology. Because if we do have that, first of all, it's more accurate, but more importantly, we can certainly recommend post-exposure prophylaxis for those that are at high risk in the same household, which is very, very, very important. Because if you look at distribution of cases, household transmission, K through 12, and a couple of environments account for a significant number of that. And I do know that our providers are doing as much as they can in terms of testing, et cetera. So this is what we have in Spokane County, and these numbers will probably change. So we've gone up and down a little bit. We do predict that this is going to continue for a while, just because everybody's back in school, everybody's back together. So we're going to start to see the transmission going on again. If you look at numbers compared to same time last year was pretty nothing, because we typically don't get that large number of cases in any particular year. And this is where I was talking about the age groups. Pretty spread. The adolescents, while we were in school, was a significant component. But if you look at it, and I'm going to show you in the next graph, some of those groups are starting to taper off a little bit. But our 0 to 4 is, if you look at it, continues to kind of peak up. So we have to be mindful of those infants, okay? And typically, when we have infants, we have household with more than one, many of the cases, and we have households where parents are exposed, grandparents are exposed, et cetera, et cetera. So we have to be mindful of that and remember that little children, particularly infants under the age of 1, can end up with bronchiolitis, or one of the more severe complications of pertussis. So it's still here. We still got to work on it. Hasn't gone away, and we do expect to see cases continue for at least a foreseeable future while it's still cold and so on and so forth. Anyway, something for all of us to be mindful of. And you probably thought about what, yes, ma'am.
Is
Sorry.
that a swab test, or what do they do to test for
There's a
pertussis?
PCR test that is done that is really good. It's a swab. So, and I do have to mention that in infants particularly, the clinical symptoms are really, really, really telling, because they do get that severe cough and stop breathing. They develop apnea and turn blue, and then they start to sometimes vomit. So, which is not typical in adults or older children. So, anybody taking care of an infant, if you see that, hear that, please talk to your provider, because we need to intervene with that. So, good question. You probably thought that we were never going to talk about Shigella again, but we're going to have a brief conversation, not a long conversation, because we have seen a few cases in 2024 and a few cases in 2025. Not as much as we saw in 2023, remember 2023, 2024, when we had the significant outbreak. But we're starting to track, so we have already been engaged with all of the environments in which transmission could be more significant, whether it's our shelter providers, et cetera, et cetera. So the team has been engaged with all of them. We've also have engaged with K through 12 and other environments in which could be, because, or fecal route touching things. So more to come on that. We're tracking. We hope this does not become more of an issue, but it is, increasing in the community. We went from 10 at the end of 2024 to about 20 right now so far. And when we start to get cases in the double digits, we become a lot more assertive with the response, which we've done very quietly. And I do have to say thank you to all of our community partners, because not only do they tell us, but they hear from us fairly quickly about what else can we do here. And it's everything from education to providing any supplies that we can. So we'll keep tracking this. Hopefully it's not going to turn into anything more than we should worry about. This is just to give you some kind of perspective on how it's spread out in 2025. And as you can tell, we start to get close to the double digits, which is where we get a little bit more concerned. But we're going to keep our hopes up that with all the interventions from all our partners, we're going to keep this controlled to the best of our abilities. Okay? We can't have a meeting in the winter and not talk about respiratory illness. I'm just going to show you the dashboard. And these are emergency room visits for the state of Washington. It kind of seems kind of flattening out a little bit. If you look across the country as of yesterday, clinical activity, meaning people that have symptoms requiring intervention, going to urgent center, primary care provider, has gone down about 5.4% across the country. Laboratory diagnosis has gone up about 18% up for the same period of time, which tells us that, a lot of people maybe are not going to the emergency room across the country or in the state of Washington. I think our providers here will tell you that we're still, this is Spokane, and if you look at this in the middle, you can tell that we are going up, not plateauing or going down like some other parts of the country or some other parts of the state. And if you talk to our clinical providers, they'll tell you they're pretty busy in the emergency rooms and urgent centers and the like. So something to be mindful, it's not too late to get your flu shot if you haven't. We still have a few more months of the flu. Good news is still H1N1, H3N2 for the most part, which is good. We haven't seen anything else surfacing in the various studies. So we still have the same strains for which the vaccine will be very effective. So your flu shot still works. Now, I'm going to do an avian influenza H5N1. It's been in the news a lot lately. It's been in the news a lot because of economic reasons, which makes perfect sense. Because if you've bought eggs recently, you've seen the impact, and it's projected the price is going to go up another 25%, which is mind-boggling. But I wanted to give you some context to our conversation because this is not new. It's not here right now. It's been here for a while, and it's impacting a lot of segments of the community. So I always try to give you a little bit of the full story, not just one piece of it. So this is across the country, like commercial flocks, and those are the ones that impact things like the price of eggs, for example. It's pretty widespread. We started to see these cases way back in 2022. It's been going on for quite some time. By now, it's fairly prevalent, and I'm going to show you Washington in a few seconds. But we also have to remember that it's also seen in wild birds, and there have been wild birds identifications pretty much in all 50 states, and Alaska, and some of the other not properties, what's the word? I just blank. It doesn't matter. It's been a long day. Anyway, so the moral of the story here is if you see a dead goose, a dead duck, or whatever, leave it alone. Call the appropriate services. Don't take it with you because we see wild birds all over the country that are sick. And they may not look sick to you, but they are. Some of them are dead. We can't forget that we also have significant impact on cattle. And the reason why cattle is important is when I show you the human cases, the vast majority of them are associated with cattle, not with wild birds or chickens, okay, which is a very common misconception. But we have seen a lot of cases in cattle. The price of beef hasn't gone up yet. It's been kind of fluctuating, but hasn't really gone up. I'm just curious to see what happens over the next few weeks. And there's a high whoops, did I go backwards? There's a high concentration in the state of California, which, you know, it's one of the major producers where we see a significant number of cases. Now, we can't forget that it also has been isolated in a number of other animals like raccoons and skunks and bears. So if you see a funny-looking bear, don't try to go and pet it. First of all, the bear probably won't like it. And second of all, it may be dangerous for your health. But just remember that household pets can become infected if they come in contact with a wild animal that is infected. And you can't, that's why we always say keep the species separate, okay? Now, boy, can you see that? Yeah, I can barely see it from here. But this is the summary of the human cases that we've had thus far. 67 cases. I'm going to give you a rundown of everything that has happened since December, because there have been a number of developments that are important. You can see the total number of cases up here, and I'm going to talk about the mortality that is up there. But you can see Washington State, the exposure associated with commercial either farms or whatever. Ours are mainly poultry. We don't do as much cattle. I think we do more poultry and eggs, although we have cattle and milk, but we haven't seen as much of an impact. Now, these are the confirmed cases, and 38 of the 67 occur in California, which will make sense if you think about the density that we just talked about. And when you look at people in general, the vast majority of the cases that we have seen is related to cattle, not chickens or other, geese and so on and so forth. So it's kind of a common misconception. People tend to forget that cattle is also part of the transmission, the chain of transmission. So if we go back to December 18, we confirmed the first severe case requiring hospitalization. The reason why that is relevant is because typically the human cases have been mild, like conjunctivitis, some like mild cold symptoms kind of a thing. This was the first case, at least in the US, in which, and this died almost, that require hospitalization. That was followed by the same patient we became the first mortality in the U.S., a patient from Louisiana. And this is, you have the slides, but just to give you an idea, if you hear about these things. Now, the potential transmission human to human is still, the probability is extremely low, but we have to be mindful that people got sick enough to be hospitalized and unfortunately passed on. This came out at the end of December in the New England Journal of Medicine. They had a great editorial. I have it if anybody wants to read it. But they did a great breakdown of at least the first 40-something cases in the U.S. And it included genomic analysis. And they started to see some slight variations in these cases compared to what the typical virus has been. So that's something that we need to keep tracking, because viruses are known to evolve, and they evolve by mutation. So depending on what the mutations are, the behavior of the virus may change. And their goal of viruses is to become more efficient at transmission. That's pretty much the goal of every virus. Now, we also know that at the same time, roughly at the same time that we had a severe case in the US, there was a severe case in Canada, in British Columbia, an adolescent that was exposed. So those are two cases around the world that we know that have been documented very well. There may be others, but they're not as well documented. Now, this happened not that long ago. Date is there somewhere, January 13th. And this is actually in the US, and I'm sure you've seen the headlines. A new kind of bird flu has been identified in California. This is actually from the World Health Organization for Animal Safety. And this is kind of like the headline that follows that report. Now, I want to clarify something. Oops, that's before. I want to clarify something with the one in California, which you can look down here. The H5N9 variant, it's not the first time we see it in the US. It is the first time we've isolated that within the context of this particular outbreak, just so we're clear. Now, the biggest difference is that this H5N9 has mutations that tie it very closely to the current strain, or H5N1, which is something that's a little bit different. So to explain it a little bit differently, although we've seen that kind of variant before, we haven't seen that kind of variant associated with the current virus. Does that make sense? Good. So kinds of things that we track just to make sure that we know what's happening. And this is the headlines on the January 27 that we just found a flock of birds, some chickens, that have become the first documented case of 2025 in the state of Washington. So moral of the story is still here, still all over the country, so we still have to be mindful and careful. We'll keep tracking that. If you read the literature across the world with all of the genomic analysis, et cetera, that has been done, there's potential for human-to-human transmission is still presented as extremely low. So, but we will keep tracking, okay? I think right now the price of eggs is probably the most significant impact that we have. It's projected to go to about $8 to $12 a dozen. And I was kind of not happy when I had to pay $11 for 2 dozen, not that long ago. So anyway, from a clinical perspective, the CDC has recommended that when we have hospitalized patients, we start to type influenza A, just to make sure that there's nothing in the environment that we need to be mindful of. So this is an advisory that came out mid-January, and these are the recommendations for our hospitalized patients and clinicians. I know that at least one of our healthcare systems has implemented a program to subtype patients in the ICU, which is a good practice. So this is probably the most significant impact through healthcare, which is an additional level of testing that needs to be done. So more to come on that. We'll keep tracking. That's basically surveillance, which I think is good. And we'll keep you posted on what, if any, findings come out of that. We haven't heard anything, and I know that the facility started doing this last week. So we haven't heard of anything interesting that may happen. And I hope we don't hear of anything interesting, by the way. Like, nothing interesting is the expected outcome, at least for us, and keeping our fingers crossed. Now, moving on, I wanted just to highlight with one slide, our public health emergency preparedness team continues to work not only internally, but also with our partners to make sure that things, our continuity of operation and our response is at the level that it needs to be. As you know, we have spent some time kind of rebuilding the whole process after COVID. So I just wanted to give them a shout out because they've done a lot of work on that. And we are, if you think about it, rebuilding the incident management team is something that we needed to do since there were a lot of retirements and a lot of people that did not have the experience anymore. So we want to make sure that we as an agency are poised not only to respond, but also help our partners in the community respond, because we do a lot of tabletop exercises with partners and so on and so forth. Not that we want anything to happen, but we just want to be ready if indeed happens so we can move quickly. So I just want to give you a shout out because it's a lot of work, and it's one of those things that we don't think about it until it happens. It's like having a spare. You don't think about your spare tire until you got a flat tire, right? And the important thing is make sure that flat tire is always ready, right? I could have thought about a better example, but that's just something that came to my mind. So with that, I'm going to stop here and see if there are any questions for us, or for me, I'm sorry. Yes.
Just taking you back to the statistics on RSV, are you hearing anything about the vaccine and whether it's effective or helping? I saw that the numbers were still really low compared to last year, but wondering about that.
We are tracking. I do know that there has been a good level of acceptance in particularly seniors but I don't have the numbers with me, so I'll have to look at it. I know that in terms of education, we've seen a lot of education in terms of vaccines as well as intervention for the monoclonal modality for those that qualify for it, but don't have the numbers with me. Anecdotally, I've heard lots of people say, hey, I got all three. And I go like, oh, okay, what's all three? And, COVID, flu, and RSV. So, but good point. I'll get that for you. Okay. Great question. Any other questions? So with that, I
think we're moving on to the community health needs assessment report. Thank you, Dr. V.
You're welcome. Thank you. I think that up to you.
Thank you. Thank you, nursing students, for joining us. You're welcome anytime.
All right, hi everybody. I'm Jazzy Landis, if I haven't met you before. I am a research scientist in the data center, and I project manage our community health needs assessment for the county. So just an introduction to what the community health needs assessment is. We kind of think of it like a road trip. So we want to look at the health and well-being of people in our county, highlighting where we are, where we want to be, and what resources we need to get there. It's part of a requirement for the Patient Protection and Affordable Care Act, which requires nonprofit hospitals to conduct a community health needs assessment every 3 years. And then for local public health agencies, we typically conduct this type of community health assessment every 3 to 5 years, and that's in accordance with the Public Health Accreditation Board standards. This year, we worked with Multicare, Providence, and SRHD to collaborate on a joint needs assessment. And the purpose of that is to reduce redundancies, so we're not going to the community 3 times instead of once. And we also worked together in 2021 to produce a community health needs assessment as well. So when we work on this type of project, we have 2 standard resources that we use. The first are the FAB standards, which we like to stay aligned with. And then the other one is a resource from NACCHO called Mobilizing for Action Through Planning and Partnerships. And this is abbreviated as the MAP. So the MAP 2.0 provides a framework to complete a community-driven multi-sector process to improve community health. It's the same resource that's used by the Department of Health when they do their state health assessment and the state health improvement plan. Something to note about the MAP is that it is held up as the gold standard in the community of public health for community health assessment. So in the MAP, there are 3 recommended assessments. We only used 2 this time around, but we did the community health status assessment. And what that assessment does is it collects quantitative data on the status of our community. So it looks at things like demographics, health status, and health inequities. We also use the community context assessment to collect qualitative data on things like views, insights, values, cultures, priorities of people in our community. So this year we used 68 indicators from more than 20 sources, and we spoke with over 100 unique people, and we spoke with 36 unique organizations in the process. I can't give you a rundown of all 68 indicators within about a 10-minute time frame, so I just want to highlight some interesting things that we saw in the report this time around. In 2018, mental illness was not a leading cause of hospitalization, but it was the leading cause in 2021. It might seem like we're trending in the wrong direction on this indicator, but it's actually a positive signal about the local healthcare system. The number of licensed and staffed inpatient psychiatric beds increased in the fall of 2018, and that was because Inland Northwest Behavioral Health opened. So hospitalizations for mental health increased because this new facility opened, and it improved the healthcare system's ability to meet the demand for inpatient treatment. So that's a sign that more people in our county are getting treated for mental illness. Another unique finding is related to a new indicator that we used in the report. This is called the Limited Supermarket Access Analysis. It's by the Reinvestment Fund, and it looks at criteria like income, distance to existing stores, and car ownership rates to identify places where households have inadequate access to supermarkets and consequently food. So this data became available nationwide for the first time in 2023, so we were very excited to include it. In Spokane County, we have 14 block groups that are classified as traveling almost twice as far to a full-service supermarket as residents in similar block groups. And I'll direct you to the map on page 38 of the report, which has labels so you can see where these areas are if you're not familiar. So these data are important because specific tactics involving the private sector can resolve unmet needs. So we can do things like bring traditional brick and mortar food retail stores, and we can also introduce options like smaller format stores or expanding existing food retail. And these can potentially benefit all of the block groups identified as having lower access in our county. And then another thing to note about tactics like this is that it combines benefit for community health, retailers, and the local economy. A big part of the community health needs assessment is prioritization. So this year we engaged community to select the criteria used to compare the issues. We also invited community to prioritize the issues. This year's results are pretty similar to previous assessments, so that tells us things haven't shifted that much. But there is one exception to this. Substance use moved up the list to take the number 2 spot, but we expected this change given the rapid increase in deaths by overdose in the last 5 years, and then also the rise in media attention and civic engagement around overdoses. So many people are cost burdened in Spokane County, but renters are disproportionately impacted by housing costs. A household is considered housing cost burdened if they spend 30% or more of their income on housing. In 2022, 56% of renter-occupied households were cost burdened, compared to 28% of owner-occupied households. And research shows us that cost-burdened households experience more financial stress and they spend less on health care. So that implies that an increase in the cost burden of households reduces access to care along the dimension of affordability. So our second priority is substance use. Substance use increasingly results in death in Spokane County. From 2019 through 2023, overdose deaths increased, and we can see that this change is meaningful by looking at the rates of deaths. So in 2018, 14.8 people died by overdose for every 100,000 residents, but this rate rose to 42.3 in 2023. And then overdose deaths are preventable, yet they are the leading injury-related cause of death in the United States. The third priority was mental health challenges. So these are things like anxiety, depression, and trauma. All of these affect health and well-being in Spokane County. The rate of deaths by suicide is significantly higher in Spokane County than in the state. And then in 2023, 33% of 8th, 10th, and 12th grade youth reported that they felt so sad or hopeless almost every day for 2 or more weeks that they stopped doing some of their usual activities. Mental health challenges featured heavily in conversations with community members, and participants oriented these challenges as barriers to achieving their personal vision of health. Mental health is an important part of overall community health, but it also contributes to physical health, their health behaviors, and quality of life. And mental health is influenced by individual, family, community, and societal level factors. So the CHNA revealed many strengths that we can leverage to tackle these giant problems in our community. In Spokane County, people uplift each other, providing social support to others in their network. They also really like to spend time with each other, and they reported finding connection as a source of positive emotions in their life, bringing things like joy to them. People enjoy supporting the community through volunteerism, especially at places like nonprofits and in neighborhood organizations like their councils. Almost 3 in 4 people provided some kind of mutual aid in 2022. This means that they provided unpaid help to people outside of their families. And then people talked about how much they love their local outdoor spaces, like our parks, which they use to build and maintain relationships and gather groups of people. So they mentioned doing things like holding sport competitions, going to the park for a picnic. So just a multitude of ways that they utilize parks and outdoor spaces to connect with other people. And successful community health improvement strategies capitalize on these strengths, and they seek to grow them. The next step for Multicare, Providence, and SRHD will be to create community health improvement plans that outline how to move from data to action. But everybody has a role in community health, not just Multicare, Providence, and SRHD. So people can join us on an individual level by creating change and doing things like making healthier choices for themselves and their families, taking action to strengthen their neighborhoods, and getting involved in community improvement efforts. Organizations can also join us, and they can do things like create healthy workplaces, align programs with community needs, and they can also get involved in community improvement efforts. So you can find the full report on countyhealthinsights.org, but we've also distributed some printed copies. And if you want to know more about the MAP 2.0, you can head over to nacho.org. Are there any questions?
I have a question. You
Yes.
mentioned that thank you, great job.
Thank you.
And I can't wait to page through it and look at all these interesting data points. I really like the way that you have it laid out, not just with the data, but also some more detailed analysis and quotes from folks that you interviewed. So nice job.
Yeah, thank you. We really tried to center community voice, so it was really important to us to include, exactly what they said to us.
So you mentioned 3 surveys or approaches that are moved forward as best practice? And you said you did the quantitative and you did the surveys of folks' feelings and thoughts about their health. What was the third area that we didn't cover in this?
Yeah, so in the MAP 2.0, they recommend, it's an overarching framework, but there are 3 assessments that they recommend to complete a community health assessment and a community health improvement plan. We're not following the MAP process in its entirety for our community health improvement plan or our CHIP, and that's just due to limited resources this time around. We're using the CHNA to build up people's awareness of the process so that next time around we can do the full process. But the assessment that we didn't do was, it's called the Community Partner Assessment. What that is a survey of partner organizations in the county to see what type of resources they have on hand. That can be money, it could be office supplies, it could be staff expertise in a certain area. So it takes a really broad view of resources and asks what resources do we have in the county. We did do a limited version of this in a workshop format, so we do have a couple of those resources on our countyhealthinsights.org page. But we didn't do a massive partner survey as part of the process this time around.
Just curious. Yes, Commissioner.
Can I ask how the participating organizations were solicited to participate?
Yeah.
I notice, one of the things that I see there's one neighborhood council that
Yep.
participate, but only that one. I
Yeah, so
noticed, and then none of the chambers, kind of the business type organizations, all of these, I just wondered how the organizations were chosen or solicited for participation.
Yeah, absolutely. So I quite frankly had to do like a cold call process. I sent over 500 emails in the process inviting different organizations around the county. So we invited business organizations, we invited all of the neighborhood councils. So tons of people were invited, and that list of participating organizations are the groups that showed up at some point in the process for a workshop, for an interview, for even a response by email that contributed to our understanding of a topic.
Excellent. Any other comments or questions? I did notice, Charlie, this caught my attention on the map, that around the Air Force Base, it's kind of like a food desert, but it made me think, I wonder if we considered the base
Commissary.
do you consider that in your?
So we actually have the same question about the data set. The data set from the reinvestment fund isn't clear whether that that consideration includes commissary as a supermarket. They do have a definition of a supermarket, so it could be that commissary did not meet that definition in their analysis.
When I saw that, I thought, well, we know there's a commissary right there on the base, and I know a lot of folks who live in and near the base obviously go there, or people who are retired military go there.
Yeah, I was looking at that map too, because I was looking at the limited supermarket access, the one that's West Colbert area. And I mean, that's an area, I mean, it's hard to tell based on I don't know exactly what these geographical lines are. But a lot of that area is outside of the urban growth area, and I don't even know if you would be able to put a supermarket, depending on what the zoning is there. I mean, if that's outside of the UGA, I mean, it's densely populated, but it's a lot of a population that was there prior to the Growth Management Act. And so I that kind of stood out to me, because I know, like, Wandermere is very close there if you're out 395, and if you're out Highway 2, there's a Yokes out there. So they're near, but also I see the definition, it's that you travel, was it greater than 2 times what other people do in other neighborhoods, essentially, so.
Yeah, and so that's where they recommend the reinvestment fund. They have a really robust list of strategies that you can use. So there's actually a third type of category that block groups could fall into. We didn't have any of those in the county, but the strategies that I mentioned, like expanding existing retail options, those are targeted towards those places where it's not really feasible to put in like a full-size supermarket. So they do recommend this really broad list of tactics that you can work with retailers to build on what's there, or to, even if it's not a retailer that provides food, but to introduce that, so that even if it's not within the same retailer, it's distributed within like a certain travel area.
The part about Multicare and Providence doing community health needs assessment, was that they need to, they're going to, they are already doing them? Or?
Yeah, so we partner so that we produce one for the county and they build off of this. So what they do is they take this report and then they add on their own materials and they submit that. You can actually find those online, so you can see, I think you should be able to see the 2021 version, and I believe the 2024 version should be available soon if it's not already, and that's on the Department of Health website. But they don't always choose as an organization to work on the same priorities that are prioritized in the report, and that's because it comes down to things like their organizational resources and work that they might already be engaged in. So the priorities in the report are not necessarily the priorities that they select to work on, and then that what they submit gives explanation of that.
Thank you.
Yeah. Oh, yes, we have Christina here from Providence.
Christina, why don't you, Christina, can you come up to the mic? Welcome.
Thank you. Okay, Christina from Providence. So as Jazzy said, yes,
Oh, is it turned on?
You
I
can
think
come to
so.
this mic.
Yeah,
there we go.
I feel like I hear
There we
myself
go.
over there. Yeah. So, anyways, as Jazzy said, yes, at Providence, we are also required to go through the same process. And for us, yeah, we add an executive summary, and then we also do a little bit of research on who else has done a community needs assessment. For example, Priority Spokane does their own needs assessment. So we also kind of take on some of the priorities that come from there. So Priority Spokane this year, it's like early childhood. Development. So we kind of look at that and go through our own prioritization process. But this year, we are pretty on point with what's in this report because it keeps showing up even from the past. Yeah.
Thanks.
Thank you.
That's great. No, I think it's a great partnership that started up. Was 2021 the first time? I thought maybe you've been partnering for a while with Providence and
I think
Multicare.
it was the first time that all three of us came together to work on
Okay.
one. I think it had been done more of like, two organizations in a partnership because Providence and Multicare weren't on the same timeline. So that's why you'll see that the timeline went from like a single year of the report to now we have 2024, 2025.
Great. Well, again, SRHD providing a great service to our partner healthcare organizations and working together rather than duplicating all the same data. And so that's really exciting that we can partner with Providence and Multicare, and we're all on the same schedule. So exciting. Thank you, Jazzy. Anything else for Jazzy? All right. Well, thank you. We look forward to seeing this. Have you done any media around it yet? Or I'm looking over at our communications folks over here. Is there anything coming up with like kind of launching the new needs assessment or key data points coming out of it?
I do have a dissemination plan, so we'll work on that throughout the 2025 timeline. So what that will look like are different products, basically, that will go to different audiences. But we tend to do a lot of community presentations. So for example, we know that the neighborhood council that participated, we're going to go back and present to them at some point. And we also tend to present at the universities and different partner organizations.
Excellent. All right. Thank you.
Thank you.
We had a couple board members that had to take off. Are there any other board members that would like to give updates? Board member Keinholz, anything to share as an update with the board?
Well, since Providence was here, I just wanted to shout out to them. I came from an Alzheimer's board meeting in Summit, and Providence was an organization in Spokane represented for the whole state, giving more referrals for Alzheimer's and dementia into the Ripple program than anywhere else in the state. And I thought it was pretty impressive, and I'm glad to see what Providence is doing in their neurology department and with their outreach for our local community who need help. So.
Thank you, Commissioner Kearns. No report, no updates. Charlie? And, well, I'm all lonely over here, but I was just going to say that I am excited. I was reached the last 2 years. Last year, Patricia and I went to the NALBO conference, lots of acronyms, National Associations of Local Boards of Health. So 2 years I've been able to attend that conference and meet a lot of Board of Health members from around the United States. And I was reached out to by the leadership of NALBO to join their national committee and kind of have a voice from Washington State on the committee, because they try and have someone from every state. And so we're going to be meeting in DC at the end of the month, which is very exciting. I had another conference planned, but I put it aside because this seemed like a really good opportunity to help drive ideas and learn about what's going on around the public health all across, but from the board member perspective, more so than the public health official. So I guess it's in alignment when NACHO, which is the public health officials, are going to DC to do their advocacy work. So we will be going to the Hill together, boards of health members and public health officials and administrators, to talk with folks in Congress and talk about public health and funding public health. So it should be really interesting. So that kind of came out of nowhere. I got an email like the first week of January. Would you like to join this committee and come to DC in a month? And I'm like, oh, okay. So I want to thank Dr. Thompson for supporting me in doing that. And I'll report back on how it goes but I'll have to zoom in to our February meeting because of this meeting. So we'll have to figure out if I can chair with the new system better, or if we need to do that. I know a lot of times it was easier for the vice chair to sit in because of the old system, but it looks like we have all the new owls or devices installed, so you can actually see and hear what's going on in the room. So I'll just have to talk with Dr. Thompson and Ann about that and see how we do that in February.
Do we know what the visual? Do we know what the visual looks like if someone is virtual and there's zooming into the meeting? Do we know what they see with all the new cameras and the new technology?
Currently, they can see the PowerPoint presentation, and they can see the person speaking at the podium. We're working, we have one more setting to set to where they can switch back and forth between the presentation and the room view.
Okay, that's good, because previously you couldn't see the PowerPoint presentation.
Right,
So-
right. But now I'm seeing all these cameras, 1, 2, 3, 4. And I guess I'm assuming that they will follow whoever is speaking in the room.
Yes, we actually have Christian, who is in the room next door, guiding those cameras to who's talking.
Wow, we're getting high tech here. All right. Well, anyway, we will see if everything is ready, and if it's too complex for me to try and chair remotely, I'll see if Council Member Cathcart can sit in. So just letting folks know that I'll be remote for that meeting. So. All right, well, if there's no further items for the good of the order, we are adjourned.